joinees, here's a little bit about us. WishwaTalks is a platform to create awareness amongst people and to protect our social heritage and to let people make their own decisions. Here, we invite experts to discuss and explore diverse opinions, different perspectives, various issues, problems, and their solutions on various fields, including art and culture, healthcare, environment, education, and many more. Each webinar is an interactive session with a deeper understanding of the topic at hand. If you miss any part of the session or would like to go through the previous sessions, kindly visit our website, wishwa.org, or you can visit our WishwaTalks YouTube channel for a full library of past WishwaTalks on various interesting topics. When we think about dementia, we often think of memory loss, but behind every diagnosis is a different person, family, and a journey filled with questions, challenges, and the need for support. Today's speakers have dedicated their careers to helping people navigate that journey with knowledge, compassion, and hope. Our first speaker, Ms. Sadia Hojo, has spent more than a decade working closely with people living with dementia and their families. From hospitals and memory clinics to daycare centers and community outreach programs, she has witnessed firsthand realities of dementia care. What makes her work especially inspiring is her commitment not only to supporting those affected, but also to raising awareness and ensuring that dementia is understood with empathy and dignity. Through her clinical work, research collaborations, and contributions to dementia care literature, she continues to make a meaningful difference in countless lives. I just got an update. Sir will be speaking first. Joining her is Dr. S. Sandeep Kumar, consultant neurophysician at Yashoda Hospitals, Somajipura. As a specialist in cognitive neurology and memory disorders, Dr. Sandeep has dedicated his career to understanding the complex workings of the brain and helping individuals preserve their cognitive health. With extensive experience in diagnosing and managing dementia, Alzheimer's disease, and other neurological conditions, he brings both deep expertise and a patient centered approach to neurological care. His work focuses not only on treatment but also on prevention, early recognition, and improving quality of life. Together, our speakers bring a unique combination of clinical expertise, research, and compassionate care. We are truly fortunate to have them with us today to help us better understand dementia, recognize its early signs, and learn how we can support brain health throughout our lives. Please join me in giving a very warm welcome to Dr. S. Sandeep Kumar and to Ms. Satya Hoshuk to share their insights on need for dementia's early diagnosis, how cognitive simulation protects memory. Good morning, sir. Yes, sir.
Sorry, it's a glitch. Good morning, I'm Dr. Sandeep, and thank you for your lovely introduction. So I will be the first speaker. Sadia will be taking over after me. So,
Right, sir.
we're good to go.
Yes, sir. Please go ahead.
I'm not able to share my screen. Can you just help me out here?
Sure. Pratyusha, just check if the co-host controls are given properly to sir.
Yes, Ahmed. Meet your co-host.
Take it contour.
I think. Huh? My slide is visible to you, sir?
Uh, I think your other device has got the co-host controls rather than this one. That's fine.
I don't know why it is getting. It's okay now? So my slide visible?
Yes. Yes, sir. You can try and check again. Your screen is not visible yet.
Now it's showing ki my I'm sharing your screen. Is it visible?
Uh, the shared screen is not visible yet.
Mhm.
So, if you could share the PPT,
Okay.
Pratyusha can share it via her screen.
Yeah. Yeah, I'm sharing this. Mhm. Krishan, is the slide visible now?
No, sir, not yet.
I think not yet.
Also, your network is not stable at the
Maybe. Okay, I can join. 2 minutes. Can you just give me five?
Sorry, just yeah, 1 minute. We'll try to figure it out.
iPhone 2.
requesting all the participants to please be patient. Please just wait for about 2 minutes. Hello, sir. Pratyusha's screen is now visible on the.
Pratyusha, is it okay?
Yes, sir. The screen is visible. Your voice is getting cut. Yeah, now it's better. Pratyusha, just check if you're giving co-host controls to sir. So,
So we can start now, right?
yes, sir.
Good morning, everybody. I am Dr. Sandeep Kumar. I'm working as a consultant neurologist in Yasaka Hospital, and sorry from my side for those glitches. Now we should start. Like, what is the topic proper? What is understanding and management of dementias? Pratyusha, can you just change? Go to the next slide. Pratyusha.
Yes, sir. Just give it a second.
So, I hope after end of this session, we can explain you what is dementia, what are the early signs and warning signs of dementia, risk factors of dementia, and what is the importance of early diagnosis and different varieties of managements or modes of management such as pharmacological and non-pharmacological managements are available to us. So we can go for next. Pratyusha? So before starting, Pratyusha, you can go to the next slide. Before going to the dementias as proper, let us meet. Next slide. We should know who are our friends or like what is cognition. Next slide. So cognition is a word which we use to describe the things or modalities by which we do daily activities. It could be memory, it includes memory, language, attention, visuospatial. Visuospatial means it helps us to orient ourselves in an environment, like which way, where I kept my purse, whether market, whether I have to take a left turn or whether I have to take a right turn. So the executive functions, which include planning, organizing things, making decisions, or solving the problem step by step, as well as social cognition. So, what is social cognition here is like empathy, sympathy. When some person is telling you his grievances, we don't laugh at them, and we respond as per the people's emotions. So this all six include cognitive domains. Deficit of any one of this can cause impairment or this is known as dementia. Next slide, please, Patricia. Yeah. Uh, So dementia is the devil in the room. So deficit in any of those things can cause dementias. So what is dementia? Dementia is an umbrella term. Pratisha, next slide.
Continue then. I will see something.
Sorry, some internet connection is there. I'm audible now, sir? Hmm. So dementia is an umbrella term which include group of symptoms or syndromes affecting memory, thinking, social ability to do day-to-day activity. So as I previously explained, deficit in any one of those cognitive domains can cause dementia. And one more thing I want to emphasize here, dementia is not normal aging. Doesn't is not a part of normal aging, which is a myth. Coming to the numbers, why should we learn about dementia? Why should we think about dementias? Around 55 million people worldwide living with dementias, and nearly 10 million people are diagnosed every year. And it affects every background. It affects all backgrounds and ethnicities. Most commonly seen in people above 65 years, but it is not exclusive. Lot of people are there, or in clinical practice, you have seen people come with cognitive impairment the age of 50, 40 years also. Produce the next slide. And among all these dementias, 75% cases are there in low income countries like India, Southeast Asian countries, and among them, 75% cases they go undiagnosed. And globally, taking care of dementia patient is costing us around 1.3 million trillion dollar. I think it is a very huge cost. Coming to the next slide. So, as I mentioned, dementia is an umbrella term. So, what are the different types of dementias? Like as we have different causes of fever, we have different causes of dementias. One of the most common which we all heard about is Alzheimer's. Others are vascular dementias, frontotemporal dementia, dementia with Lewy body. Among them, most common is Alzheimer's. Other group known as mixed dementia is the most commonly seen in older people above 70 years. That is mixture of vascular dementia, mostly Alzheimer's. The next slide. Now, before going to dementia proper, hmm, next slide, please. Pratyusha, next slide. So before going to the dementia proper, I just want to know, I just want to emphasize here the difference between normal aging and what is worrying forgetfulness. It is normal forgetfulness and abnormal forgetfulness. The normal, the see, all memory losses are not dementias. I have seen a lot of people coming to OPD complaining, I am forgetting, I may develop Alzheimer's. I'm not able to do this thing, I'm forgetting name of the people, I may develop Alzheimer's. Usually, those people are not forgetting, or we can say they are not developing dementia. It's a normal forgetfulness. So, what that is the difference between normal forgetfulness and went to or the abnormal one. Like occasionally we all forget names, but when we try to think about it or we try to remember it, we can remember the name. But forgetting close family members' name like your sister, your daughter, your cousins, your brothers is abnormal, and never able to recall them is also abnormal. Sometimes we keep something somewhere, and but we are able to retrace the object is normal forgetfulness. But putting the object in some abnormal places, like keeping, for example, water bottle in your wardrobe, keys in your refrigerator, and forgetting about it, and you won't realize you are keeping something that is abnormal. We may forget tracks of the day, like what happened on that day or what happened this day, but after rethinking about it or after putting emphasis, we can able to recollect. It's normal, but we lose track of whole days and night, and we do not remember. That is abnormal. Forgetting, sometimes we may have word finding difficult. It is unable to find the right word mid sentence. Is okay, but forgetting complete word or using of wrong names or asking or repeating same thing is abnormal. So one should be very much clear about what is normal aging and what is worry forgetfulness. That is the next slide. So what are the early signs? Now coming to the, we discussed about the early signs, abnormal age and forgetfulness. What are the 10 early signs we should remember or we should all be very critical and be aware of? It is memory loss, which disrupts our day-to-day activity. Like I'm paying same electrical bill 2 times, forgetting appointments, forgetting events we went. We face trouble completing familiar tasks like a housewife who can close their eye, can cook rice and dal, or a banker who can calculate in minutes, but they face difficulty in doing those activities. Visual spatial problem, like I'm getting confused in their own house, like the house they were staying for 10 to 15 years, now they are unable to recognize which is their room, which is their children's room, which where is the washroom, where is the kitchen. Similar way, misplacing things frequently, withdrawal from social activities, and then change in the part. For they start behaving very abnormally, doesn't want to meet with people. The person who used to enjoy watching movies suddenly is very withdrawal and doesn't want to watch movie. Difficulty in problem solving, getting confused in time and place, difficulty in using languages, and doing very simple judgment mistakes, like cooking, putting the gas stove on the switching, forgetting to switch off the gas stove, or removing the rice before it is cooked properly, change in the mood and personalities. These are the 10 early signs which one should always be wary of. And if you find any of those things, you should always reach to a GP. Next slide, Pratyusha. So, how dementia is diagnosed? Dementia is diagnosed after seeing those early signs. One should reach your general physician, give a complete history, and he or she will do the cognitive assessment. We have scales which can be, this is a question answer based, MMSE, MOCA, AS, which are all adapted to our Indian culture, Indian language, and thinking skills. After that, we can run some blood tests to rule out any other causes of dementia, such as vitamin B12 deficiency, thyroid issues. Some chronic infections can also cause memory loss. Then scans followed by specialist review. Next slide. So, what are the different stages? I saw somebody has asked whether all this start together, or what are the stages of dementia. Dementia can be divided into, or we can say, rather we can use the term cognitive impairment instead of dementias, because dementia has a very taboo associated with the name. So we will be using the term cognitive, neurocognitive impairment or cognitive impairment, and we can group into three parts, or three stages. One is known as SCI, subjective cognitive impairment, where patient may have memory loss, may be doing, may be facing difficulty in doing the activities, but on routine cognitive assessment, they are normal. MRI may or may not be showing atrophy. MCI is just like, we can give the closest example we can say is diabetic. One in risk for diabetic, patient is having pre-diabetic and diabetic. So is SCI is patient is having risk of diabetes. MCI is like pre-diabetic, where patient have memory loss, but he is able to do all his daily activity. He can go out, he can take care of himself, he can dress himself, he can take bath, he can eat himself. Next stage is dementia, where the patient is completely dependent on their caregivers for the activities. So most of the people coming to our clinic, or 90, I can say around 80 to 85% people of dementia are in this SCI and MCI stage, and very rarely people go to dementia, and people tend to stay in MCI and SCI for years long. Okay, next slide. So, what are the risk and protective factors of dementia? You know, we till now we discussed what are dementias, what are the cause of dementias, what are the early warning signs. Now, coming to the risk factors, or we can say the factors which influences the progress of dementia and how to strategize and prevent it. The factors linked to dementia are always the age. Age is always a risk factor which is non-modifiable. We cannot change. We cannot be young. We anyhow will always grow old. Other things which are like, you can see below this line, those are all reversible. Those we can prevent, like early quality of education, hearing loss, high cholesterol diet, depressions, brain injuries, lack of physical activities, visual impairment. So all the sensory impairment. If a person is having cataract, a person is having hearing loss, if he doesn't use those devices, doesn't correct those things, may end up developing cognitive impairment. They may not cause the cognitive impairment, but they will contribute to the progression of the disease. Similarly, alcohol intake, sedentary lifestyle, high blood pressure, smoking, diabetes, socially isolation. You would have seen a lot of people with dementias. There is a jump in number of patients complaining with memory loss after COVID lockdown, and which puts an emphasis of social inactivity or social isolation. Similarly, air pollutions. Next slide. See, as I previously mentioned, in 1 in 3 cases of dementia can be prevented by addressing those risk factors, increasing education. If we learn new language every day, if you try to read new books, if you try to keep ourselves active, nothing. You can go for a morning walk and evening walk. Be with people, contact, go to kitty parties. You can go to social gatherings, controlling your blood pressure, obesities, smoking, uh, getting treatment for diabetes, depression, hearing loss, all can prevent your dementias. So dementia as such is not a taboo, or it is not preventable. It's more like a disease which we tend to get it, or we tend to purchase it. Can you get next slide? Now coming to the so now coming to the management part. We got um,
They are asking you to start the video.
now I am very much clear about what is dementia, what are the risk factors of dementia. Now coming to the management. So what are the management available for dementia? We can divide into pharmacological management and non-pharmacological management. Pharmacological management are the medication which help us to manage the dementia symptoms. Non-pharmacological, which my next speaker will explain you in detail, is plays a very important role in diagnosis or in management of dementia. So, a lot of people tend to stick to the pharmacological management. They look for the treatment. They go to the doctor. They come doctors. They do doctor hospital shopping or doctor shopping. They are looking for the cure. So as I'm a clinician, I will be focusing on the pharmacological part, but we should always put emphasis on non-pharmacological part along with pharmacological part. Patricia, you can go to the next slide. So, so pharma management overview. What is the overview? Like we have, first of all, we should understand there is no drug cure for dementia. The medications are aimed to slow the cognitive decline, slow the management symptoms, improve the quality of life. What are the medications available? Cholinergic inhibitors, NMDA receptor antagonists. I want to put emphasis that these medications are predominantly for Alzheimer's type of dementia. It may not work in every. Coming to the next slide, sir. So 90% of people kind of psychiatric disorders or psychological symptoms. We won't say it is a psychiatric symptom. I will say it is a neuropsychological symptoms, which include
So just a
agitation,
second, your
depression,
audio,
anxiety, psychosis, sleep disturbances. They
just a
usually
second.
come
Hello,
because patient have
hello.
some unmet needs. Like the patient will be telling, like, I want to go to washroom, but he is not able to convey it, or she is not able to find the
Uh,
way to the washroom, and they may get agitated, they may get irritated. Yeah. So ideally I will advise you to first cater to that unmet need. Like first understand why he is getting agitated, why or he or she is getting depressed, why he or she is having anxiety. If at all you are not able to control by those non-medical way, or patient is so much aggressive or so much violent where she can harm you or harm herself, then only we should go for these medications. And this medication should be taken for a very least duration and least dose, because they also come with their side effects, such as your antipsychotics like risperidone, which I have mentioned here, can increase your Parkinsonism. They may cause increase in drowsiness leading to fall. I won't say we should not use this medication. I want to emphasize here is we should use this medication, and this medication should be used in a very least dose for the least durations, but should be used. Pratisha, can you move to the next slide? So, what are the newer drugs which are coming to the coming for the management of dementia? There is a budge now for this anti-amyloid therapy or anti medications for the Alzheimer's, which are available now in India. They are lecanemab and donanemab, and they target the biologicals, not the pathological pathology behind the Alzheimer's. That is the amyloid plaques. They don't treat the symptom; they treat the pathology, and they work in very early stages, putting emphasis on early diagnosis of dementia. But they don't act if the patient is coming in stage 3, stage 4, or stage 5 of cognitive impairment. They work in stage 1, that is an MCI or SCI or an early stage 1 disorders. Okay. So these drugs are lecanemab, donanemab. They are monthly infusion, monthly or twice monthly infusions. They should be taken for 18 months. They have their own risk factors. They have their own contradictions. Come to next slide. So one of the key points for the pharmacological treatment here is medications can significantly improve quality of day-to-day activity and should be taken in a judicious way. You should start slow, go slow, and try to give to the minimum dose for minimum durations. And you should always visit your doctor regularly. If you look the fourth point, there is no current medication to reverse or cure dementia. I think I should go back and say it is not completely true, because there are medications which I have just previously I have shown you, lecanemab and donanemab, can to some extent stop the disease progressions. Polypharmacy is always a risk. Giving 3 or 4 antidepressant, antipsychotic medications can make the person drowsy and increases the risk of fall. So all those things we should be very much cautious. But pharmacological therapy is also very important thing. Next slide, Pratyusha. So coming to dementia in India, why it is how dementia is in India and what is the present scenario, Indian scenario in dementia? Can you go next? So as we know, India is a rapidly India in India there is a the aging the people with 60 years old population is gradually is increasing, because till 1950s and 60s or till 1990s the non-communicable diseases were most prominent. The communicable diseases were causing a lot of deaths. Now, when we control those communicable diseases like malaria, dengue, diarrhea, cholera, and also we have improved our cardiological treatment for coronary angiogram, CAD, and all those things. We have increased the age span of our people. So older people, there is a rapid increase in aging population of our country, and which puts back dementia, which brings dementia into focus, because the which previously dementia is not in the focus of anybody, even the insurance company or in the government of India focus. So, what is the current scenario? There are around 8.8 million people living in dementia. We can say one in among 27 people above 60 years is developing some kind of memory loss, some issues, which is grossly underdiagnosed. And you can see only 10% of people in India are either diagnosed or able to reach facilities where these dementias are treated, or any they are reaching for the medical care. Okay, next slide. So, what are the unique challenges and opportunities in the Indian context? So, in India, still now, dementia is a taboo. Taboo. I've seen a lot of people who they don't tend to discuss what are the abnormalities or what are the complaint of the patient. They will discuss with the physician or one doctor. second doctor, they may not able to open it up, or only one person will open up, one person doesn't open up. And still there is a belief that dementia is a disease disorder of older people. I've seen a lot of people who come from dementia. It is seen in 60 years old, or is a disease of older people. Why should we think about it? And it is true among physicians also, general physicians. I'm not talking about all the general physicians. I'm talking about some general physicians. And there is an insurance gap. A lot of insurance companies, they don't cater the dementia part. And one unique thing is that India is a very diverse country where different people, different languages, different cultural beliefs are there. So putting everything in a one criteria or one standard of diagnosis is not possible. We should develop new scales and new way to diagnose dementia as per their own as per their own cultural and ethnic and language basis. I cannot diagnose a patient with dementia or a patient who have a language issue who doesn't know what is a pasta, right? He would have eaten pasta at all, and he doesn't know pasta. Same way, I cannot tell a patient has cognitive impairment, a North Indian people who doesn't know pongal, or South Indian people who doesn't know litti choka. So they are two different things. I cannot say ki, like, if I don't know this one, he has cognitive impairment. Litti choka is very common in northern India, so is pongal in southern India. So these are the drawbacks. So these are the unique challenges. So what are the opportunities which I feel is still uh, helping in the helping to dementia patient, dementia care is the joint family structure or the support, strong family support culture. Like, okay, a older people is there, we tend to take care of her, we tend to speak with her, grandchildren tend to play with her, and traditional practices or the cultural thing. We still are religious. It may sound controversial here, but I want to put emphasis. I'm not putting only in that one religion. I'm telling about all the religions. So all these weekly congregations, your bhajans or Sunday masses, what they do, this all are the part that Sadia will explain you about the cognition stimulation therapy or the social gathering, where those activities they tend to activate your brain networks. There we go out, we meet with people, we meet our near and dear, we discuss about things, we play the music, rhythms, all those things help in uh, decrease in the cognitive impairment. So instead of looking at this in the religious view, we should look at as a way how we can cater those cognition stimulation therapy among people, normal people. And there is a growing network of memory clinics in our country, like ARDS. I have started before. We in Yasoda Hospital have a memory clinic with a neuropsychologist, Sadia, only doing the activities. Same way, we have in Nimhans, Bangalore, where we are reaching to the people and we are taking care of the patients. Now, a lot of technology reach is also there. People are using WhatsApp, people are using mail now, platform like WishwaTalks, and those people, they coming together and they are helping to raise the awareness about dementia among the people. Coming to the next slide, Pratyusha. So I just before ending my talk, or before handing over to Sandhya, I just want to bust some myths and facts about dementias. So, what is the most common myth we all people are just asking you? You would have thought of dementia is just a normal aging. Everyone gets forgetful. Over 60 years. In Hindi, we say "satya gaya." Maybe the slang is very bad to some people. I'm just saying it. So in Odia also we say "budha age." So just like saying dementia or forgetfulness, a person is getting old, forgetful. No, dementia is a disease which is more common in older people. Not all older people are forgetfulness. Nothing can be done. Dementia, nothing is a degenerative disorder, nothing can be done. No, that is not. Early diagnosis or whenever you're diagnosing the patient, we can reach to the healthcare facilities where they can give you medication, therapy, support, planning, future planning regarding how to improve the quality of life. Number third myth is only old people get dementia. No, people with above 40 years also present with cognitive impairment. There are some dementias which come in as early as 35, 40. Frontotemporal dementia is very common in younger age group. Familial dementias, especially Alzheimer's, can also come 50, in mid 50s and 60s. People and fourth most common is people with dementia cannot live a meaningful life. No, they with right support, right activities, with right therapies, they can stay independent, especially in the early stages. So our target is to keep those patients in a very early stage, not should not let them progress. And how to keep them in early stages, early coming to the doctor, yeah, whenever you are seeing those early tense warning signs, taking the medications regularly, getting doing physical activities, controlling your blood pressure, sugar, diabetic medications, having a proper sleep, and other things which Sadia will explain you. That is a non-pharmacological part. Thank you very much, and I'm sorry if I have offended anybody here or have told something bad. And I just meant because I saw the chat, like somebody has raised the question, like I should not use the term doctor shopping, but I'm very much sorry about it. I didn't should not use that part. Okay, I'm handing over to Sadia for further. Okay. Thank you.
Thank you so much, sir.
Hello.
Hello,
So,
ma'am.
yeah, hello everyone. Good morning. It's lovely to see all the participants here. So, without taking much time, first I would like to thank Dr. Sandeep, who did a brilliant job explaining the complexity of dementia with respect to the nature of the disease, and then with respect to how culture can be challenged, and then all the different things that he just spoke. Yes, I think it's brilliant.
Ma'am, just a moment. We are losing audio. Kindly recheck your network once. Hello.
Next
Yes,
slide.
ma'am. We lost your audio for a bit over there. No, not at all. I think it's audible again.
Okay. 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 You can hear me. Yeah. Sorry for the network. We are not sure what's happening here, but we'll try our best. Uh, did the slide change on the screen?
Not yet. It's still myths and facts about dementia. Um,
Next slide. I would like to start my talk saying that every time when we are saying that the Indian scenario of dementia and why we are talking so much about the public awareness and people should understand what to do. The thing is that when we are quoting the numbers, right, you saw some numbers which were so huge. Like there was something like 9 million people with dementia in India currently, living with dementia right now. That is just not the number for the person. I would say it is the 9 million families who are impacted. So it is like the 9 million unit of families who are impacted with dementia. So dementia is not just like, it is impacting the person with their cognition or daily activities. It is the entire family unit which is getting impacted. Like somebody has to supervise. Either it is like an emotional burden or a financial burden or a physical burden. So here, that is one reason why there is so much emphasis on how to manage dementia, how to prevent dementia. and early diagnosis. That is our main, objective today, to let the public know that the best thing is that early diagnosis will help for a longer run. It will help to cut down the financial burden to some extent, to emotional this thing. So as you see the slide, um, I'm going to talk about non-pharma management. So when we talk about non-pharma management, it is basically not involvement of medicine. Yes, whatever the doctor prescribes you, you have to follow it. You have to take those medicines. But at the same time, there is other part of treatment in dementia. So one would be the non-pharma management, where there are cognitive stimulation activities, cognitive psychosocial activities, and then there is caregivers management. So these two parts that I would like to emphasize more on. So when we talk about the non-pharma management, it is basically to aim, like, to help the person with cognition, behavior, their functionality, functional rehab, and then it also helps the caregiver or the family to connect with the person, to understand the person. So as Dr. Sandeep rightly, he said at one point that everything that is happening, the psychological issues, it is more like it is he mentioned that sorry, there was a call. So so he just mentioned about the things, I'm sorry, I lost the thought of my this thing trail of my thought. So our aim is basically for the cognition and behavior, and which includes a lot of therapies, environment changes, and caregiver support. So that is what we are going to see over here. Next slide, please. Yes. So basically, what I was saying is that Dr. Sandeep did mention that there is an unmet need that happens, and that is the reason why we see that there are a lot of psychological issues that happen. So when we are talking about the neuropsychological issues in dementia, which is like agitation, anxiety, or other things, there is a major chunk of time that happens is like there is an unmet need, and that is the poor communication. The dementia person loses their language or the ability to speak or communicate, comprehension. And that's why they are not even able to say the basic things, something like, I would like to have a glass of water, or I would like to have maybe some pain medication, I have a headache. So they're not able to communicate. So when we do these cognitive stimulation therapies or non-pharma interventions, there's a very good chance that a good rapport or a new rapport or a new relation is formed between the family person, who is the caregiver, and the person with dementia. And that definitely helps to build that bridge where the communication is not playing, or I should say the verbal communication is not there. So cognitive stimulation therapies or the other therapies that I'm going to talk about now, that definitely helps to bridge in this gap. At the same time, as I mentioned, that it will help to cut down a good amount of burden, which could be like emotional burden, financial burden, or even like a constant physical burden. So when we talk about these cognitive and psychological therapies, the major part is like cognitive stimulation therapy, where we do a lot of activities like puzzles, music, based on the person-centered approach, where understanding what the individual was in the past, what was their background, their culture, their education, or what part they come from. So based on those things, then we help them identify like things that they would be interested in, and we work on as a cognitive stimulation therapy to help the domains that are impacted by dementia, so that at least it can retain for some time, or the progression of the disease will slow down for some time. The other things that are done generally in the non-pharma interventions is like reality orientation. Like people with dementia will lose orientation, they don't understand the time, or you know um, or the place. So there's a therapy which is called reality orientation, validation therapy. A lot of time, the person with dementia would speak of their past memories and not the current memories. So a lot of time people would somebody would come and say, "Oh, where are my parents?" And we end up just saying that, "Oh, they died long years back." and that might just trigger off that trauma every time that they get this answer that, oh, they are not there anymore. So something like that can be taken care by a validation therapy, or where we can just help them to understand, or in some cases just go by the flow by saying that okay, or just diverting them. So when we talk about these cognitive stimulation therapies or the activities, the meaningful activities, they can be a very good way to divert the mind when there is a very a difficult situation or challenging behavior that is happening. The other things are like psychological therapy that definitely help to some extent in mild stages, and then there is reminiscence therapy. Next slide. So I'll definitely try to take you through all these things in a small way with some pictorial slides coming up. Then physical exercise is something that is very that can be very helpful, of course. And then we have identified like music therapy, people who liked music. So all the therapies that we are mentioning over here, it is based on like the person's interest and more like a person centered approach. If a person has not done, like how Dr. Sandeep gave the example of pasta, like if somebody has not eaten pasta, we can't tell them to eat pasta right now or to enjoy or understand that thing. Similarly, like somebody who has not probably heard music, we can't say that yeah, music therapy would work for them. In some way we can derive music in a different way, maybe not songs, or sometimes it can be cultural or religious. So we need to understand what is the person's past and their likings, and the same thing can be incorporated now based on their current cognitive status or the current domains which are working. Next slide. Art therapy is also something that works very well in this case. So when we talk about the non-pharma interventions, of course cognitive stimulation and all these activities are very essential and a part of it. At the same time, having a structured routine is something very important. Literally having a timetable, how we had it like in our school, because there is always a body clock. Even though a person with dementia may not understand that what is the time, or they are disoriented, but if they are fallen into a routine of their meaningful activities, or doing certain things at the same time, something like how we have lunch, like we know that it would be for the lunch time. We don't have to look at the clock to say that, oh, this must be my lunch time, that's why I'm hungry. Sometimes it's like you yourself, in the reverse way, you would say, oh, I'm hungry, it must be 2 o'clock already. So that's a body clock that works. And then that's the same thing we can try to incorporate for the person with dementia also, where we do meaningful activities which they thoroughly enjoy or they feel comfort into. And they will be looking forward to it. The only catch is that, yes, we will have to spend a lot of time. So it comes with a lot of patience, time investment to get to that kind of a routine. But trust me, I have seen people over years who have fallen into that routine where, say, if they are used to some sort of a fun activity or a meaningful activity at 11 o'clock in the morning or something, they would be looking forward to it since morning, that they probably can't communicate or tell you that what they are looking up to or what is the thing that they're waiting for, but they know somewhere in the back of their mind that, oh, there is a comfort time which is coming, or there's a fun time that I'm waiting for. So that's something that helps for a longer duration also, as the stages also increases. Other thing is dementia friendly home, which is like environment modification, something that helps for fall prevention, and also like which can reduce confusion in people with dementia. So good lighting, contrast colors, the colors that the person with dementia would see even to a later stage of their disease. There is a high possibility some people with severity of dementia might have confusion with dark colors or grays or certain tones, or the visual spatial would be impacted. So in that case, what we recommend is like environment modification. A lot of assistive devices are used for wandering. Dementia has a symptom called wandering, where people just walk out without any sense of purpose, and they forget to where to come back. they might forget the house address, or they might just wander off. So a lot of assistive devices are in the market right now, and that can be used. So if you there are GPS tracking system, there are fall prevention assistive devices, or there are medication dispensers. So to some extent, these definitely help in our intervention. Then social engagement, as Dr. Sandeep rightly said, that go out, meet people. When people get diagnosed with dementia, family automatically tries to cut them out. Maybe it can be a social stigma, or just a perception that the person can't talk. See, the person can, maybe the communication is gone, but the insight is there. The individuality of the person with dementia is in there. They do understand that, oh, there are four people in front of me, but they are not talking to me. Or they are going out for shopping, but they are not taking me. They may not putting it in words, but they will definitely feel it. So every time they are just like, putting all these things inside, the negative points, and one day suddenly it blasts off into agitation, or a very physical or physical aggression, or some irritation they will develop towards the family. So a lot of time we have seen that these are the small things that will convert into challenging behavior. Of course, it is very challenging to take them out, but a very controlled environment, or just going out for a park, supervise them, maybe to go to a mall. All these things are very important. Getting them to their friends just having a coming over and having a normal chat makes a lot of difference for people, with dementia, because they also get that sense of importance, that and the sense that, oh, I am normal, people are talking to me. Then I see some questions. Maybe we'll take it after we end the presentation. I'll try to finish it within 5 to 10 minutes. Is that okay, Prashant? Next slide. Okay, thanks. So next slide. Yeah, so every time we are talking about non-pharma interventions or cognitive stimulation therapy, why? We spoke about medication, that yes, it will help to slow down the progression. Unfortunately, there is no medicine that will cure the disease, but we do have a lot of means of medical treatment, non-pharma treatment, to slow down the progression of the disease. And this is what we are emphasizing over here. So when we say slow down the progression, yes, it won't be like a fast neurodegeneration of the particular disease, but at the same time, it will also help to control the behavioral issues, the challenging behavior that we are talking about, that comes with the disease, like with Alzheimer's or the other cognitive impairments. So first thing is, yes, it delays the progression of disease. Then it will, it will help in positive emotions. As I said, that it fosters the communication between the caregiver, the family, and the dementia person. When you do these fun activities, when you do these non-medical interventions, spend time with them for social integration, or music therapies, or the other therapies that I just mentioned, it will definitely make a good rapport. Maybe not like how a normal person would have a rapport, but in some way, yes, a positive connection between the two people. So it will help to cut down the challenging behavior. It will help to maintain the functional abilities, which is a very important factor for dementia care, where we want the person to be able to be independent, to do their things by themselves, like what we call the basic activities of daily living. It will help to improve the confidence that, oh, I am able to talk to people, I am able to do the activities, like even though it's a small thing. Then it definitely helps the quality of life. And I think all the things that we are talking about eventually comes out to the point that it is the quality of life that is important for the person with dementia, like and the family and the caregiver. So I feel that this is like a package that can help with all these things. But yes, it takes time. It needs that understanding that how it works, but it's nothing like a rocket science. It is something some very easily doable. Next slide. Yeah, so this is reminiscence therapy. We can go faster on the slides. So where reminiscence therapy is like, using the old cues, like using the old photographs and helping them think about the positive or the happy memories that they have. So because the long-term memory will be intact to some longer durations, they are comfortable talking about these things. So on the screen you can see, like, people trying to recall things. And then we have a concept of memory box, where it's like we just try to compile all the things that they still remember, and they still like can connect to it, like something like, oh, this is the teacher trophy that I got, something like a souvenir or some sort of a thing that just elicits that happy memory where they can talk. That just makes them feel good. So reminiscence therapy is definitely a very good way, to incorporate cognitive stimulation. Next slide. And the best part about reminiscence therapy is, like, we don't have to do a lot of homework for it. Each house will have like a display unit or a showcase where we have had things for years and years, compiled them from our travels, souvenirs, trophies, photographs. That's exactly the memory box that we need. And that's all, like, a person with dementia really need to stand there for 10 minutes, and they will have those old memories and happy memories coming back, and they will talk. All we need to do is like just stand there and be there to listen to their stories. So this is more like, on the slide we can see that there's stimulated presence therapy, where it's like, we do a lot of audio or video stimulation thing, which will help to reduce the anxiety, agitation. Next slide. It also helps in social engagement, social integration, which eventually helps people to come out of that loneliness. A lot of time our elderlies are just feeling lonely. That can, trigger off, like, feeling depressed. Then the validation therapy is something, as I just mentioned, right, at the start of the talk. So it helps, like, the confrontation rather than correcting them for the facts, because they don't have the factual memory, because of the short-term memory loss or the cognitive impairments. They're not able, the person with dementia is not able to give you the factual things. It doesn't mean that we confront them for it. If they say that, today morning I had something very weird, for example, if we ask them for breakfast, and if they say that, yes, I had like maybe dosa or idli, and in reality they have had maybe just bread and omelette, it doesn't matter that what they are saying. It is, we need to let go of that, getting that right answer from them. When we as caregivers, we understand that, okay, there is a disparity. So avoid those kind of confrontation, because every time we're going to fight back, no, you did not have this, you had probably something else. They are not going to believe, and then that will, develop into something negative. They always think that the caregiver is trying to correct me, the caregiver is trying to control me or order me to do certain things. Next slide. Orientation therapy, we can help them with a lot of cues. So this is a slide which, gives a lot of idea that we can have things that can be easy. Our house is like, we have a lot of things which are for normal people. I think it's maybe for the aesthetics and the things that we have picked up. But now we need to start for the dementia person, like if they have lost their domains, or they are, the cognitive domains are impaired, then how we are going to help them with cues that will help them to feel good. Like if they're not able to read the clock, maybe we can give them like a digital one that will make them feel good about it. Or if they're forgetting or getting confused with where is the bathroom or where is the kitchen, we can put like cues that will help them. So these cues definitely, see, all the things that we are talking about contributes like to some small extent. And that small, like say, realization orientation, that will give, or the cues will help them 5% or 10%. The reminiscence therapy will help for 5% or 10%. So you're adding up that, and then it helps to a larger extent. Next slide. Sensory stimulation. If you think about, like, there are so many things in our house that can be used for stimulation. as I said, it's nothing rocket science. Like, all we need to do is like think of what was their life previously, how, like, maybe a woman who had like, who she was a homemaker, or what are the things she really enjoyed, going to the kitchen, maybe cooking. They may not be able to do what they were doing 10 years back, but they still can do a part of it. So we need to, like, cut down those tasks into very small bits and help them still achieve those things and feel good. So here on the sensory stimulation, I've given some examples of like, sensory stimulation, aromatic things, aromatherapy, and next slide. That will help them, like, elicit the older memories and think about it. Maybe think about the previous festival or something that they have been part of it. So we need them to be more active. Remember that they are not patients, they have a disorder. So it is not like physically they are fine, they're doing well. It is cognition that is impaired. So all we need to do is, like, with all possible ways, stimulate their cognition. So here we see music. As I said earlier, that if somebody was interested, that will definitely, music can definitely help them. Playing instruments, or it can be just listening to music, or it can be singing along. So this can be a very good way which works. Next slide. Yeah, so this is more like a sensory stimulation, and it's basically multisensory stimulation therapy, which is used in the Western world. So, and it is nothing like, we can do it at home. It's something very simple to do. And I think the way Amazon, or a lot of platforms have made it easy. Everything is available online. We can just have like light sensory instruments, or some aromatherapies. So basically, a sensory stimulation intervention is where you have like the light sensations, the probably the temperature of the room, or probably the aromas that, and there's a lot of tactile sensations. All these things basically help to calm down the person. So it's more like a therapy. Like, you let them in the room for an hour, or an hour could be a long time, but half an hour or 1 hour, and they feel comfortable with it. So the point is, like, the more they are they are feeling less anxious, less confused, it will definitely help them feel calmer. Next slide. Yeah, so just some pictorial examples of the therapies that we use for non-pharma intervention and cognitive stimulation. Next slide. Yes. So supporting carers. So I think one part was the medical part, which Dr. Sandeep spoke, and then the second part was like cognitive stimulation, functional rehab. That is what we spoke. And now the third part, which is very important. So this is for the caregiver support, where we understand that the family is having a lot of impact. The person who lives with the person with dementia, the direct caregiver, the primary caregiver, can have a lot of stress. So when we talk about stress, it can be like emotional, physical stress, and a lot of financial stress also. So a lot of time we try to help the caregivers. See, one thing is that dementia is actually a journey. It is not like you come for one session and it is the end of the story. As the journey progresses, the disease progresses, there is like a lot of different symptoms which arises. So every time there has to be a psychoeducation for the caregiver. New information has to be learned, that how to manage symptom, or how to manage those particular things, the new things that are happening to the person with dementia. So there has to be a constant a professional and a caregiver support system. So next slide. We try our best to reach out to the caregivers. So yeah, this is exactly what we were talking about, the three different parts that we broke down into how to manage dementia. Next slide. Yes. So today's our main intention was of this talk, early diagnosis, why it matters more. See, the we get, so over the years of my experience, like we get to see patients only when there is a problem with the family that they are not able to manage the symptoms. When there is a very severe stage of the disease with a lot of psychological issues or cognitive issues, when the family just can't manage, and that is the time they first seek the medical attention. And so many times, like when I ask them, okay, there is, your medical record do say that there is like some sort of a dementia or cognitive impairment, and we didn't know there is any treatment, because the perception that we have is that there is no cure. So we just come to a deadlock that, okay, as there is no cure, there's nothing can be done. No, that is not the case. Yes, there is no cure, that is the right part, but then there is so much that can be done, and that is the reason why we try to reach out to you, to make you understand that yes, if you identify these symptoms, the best thing is to reach out to a doctor to get a diagnosis and then start the care management. Next slide. Yeah. So the takeaway today, like Dr. Sandeep also spoke and emphasized so much on, dementia is not normal aging. It is a condition which needs a medical attention. We need to identify and learn the 10 warning signs or the basic warning signs so that we can help people recognize and lead to medical interventions. Early diagnosis is a key over here. The sooner we know, the sooner we'll be able to incorporate. So it is not only for the person with dementia, it is also for the caregiver. So the sooner you know that what you are going through, when you start naming it that, oh, this is my caregiver stress, it will help you to, take actions for it. So, and then of course the medication will help. So there are so many non-drug therapies that we just spoke about. So dementia, as I started with my talk, that it is not the person who is getting impacted; it is the entire family unit who is getting impacted. So it is our whole community which is impacted by dementia in some form or the other. And for the carers, there is like, it is as equivalent to the treatment that we are providing to the person with dementia. The carers also need that kind of support. Next slide. Yes, next slide. I think I'm at the end of it. Yes, thank you so much. And it was lovely. Sorry for the delay. I'm not sure about the network was slow or something happened, but it's always a pleasure to be at WishwaTalk and, talk about dementia, reach out to the general public. Thank you so much. If you have any questions, Dr. Sandeep is also available. We are happy to answer those. Thank you. Yeah,
Thank you so much, ma'am.
Krishnan, sorry, if you can just put back the last slide. Yeah, so at Yashoda, we have the memory clinic where we are trying to, incorporate the medical and the non-pharma interventions. So Dr. Jaydeep Ray, he's the HOD, and he's leading the memory clinic over here, who specializes in dementia. Dr. Sandeep is there. So, and we are trying to, develop a memory clinic to reach out to people with respect to pharma interventions, non-pharma interventions, and of course the caregiver support. Thank you. That's all.
Thank you so much, ma'am. Thank you so much for the wonderful, comprehensive presentation that you put up. And thank you to Sandeep sir as well. Before we
Yes.
move on to the Q&A, I'd like to just take 30 seconds of everyone's time for a quick poll. This will help us get to know you better and tailor future topics that we bring to you. A big thanks to everyone here today. Your presence and participation means a lot. While you fill out the poll, I would also like to extend my heartfelt thanks to our esteemed speakers, Ms. Sadia Herzog and Dr. S. Sandeep Kumar, for sharing their valuable time and insights with us. Uh, Requesting everybody, Pratusha, could you please put up the poll questions? While you're filling up the poll questions, I'd like to mention about the future talks so that we can go ahead with the question and answers uninterrupted. We have PG Bhatt, sir, President and Director of Pluma. He's going to talk on Your Vote, Your Voice, Understanding Electoral Role Revisions in India. This is on 20th June 2026, 11 a.m. onwards. We have Ritika Chawla, educator and environment enthusiast. She's going to speak on Less is More, how minimalism can save the planet. This is on 4th of July 2026, 11 a.m. onwards. I'm going to, for anybody who's missed any part of this particular session, um, I'm going to paste the link of this particular session, the recording of this session, in the chat box right now. You can share the link with your friends and family and ones who might find it helpful. Also, you can save it for yourself. Requesting all the participants to quickly interact with the poll question so that we can move on to the Q&A session. I don't see anybody interacting with the poll questions at the moment. Pratyusha, kindly turn off the poll and end it. Um, Sadhya ma'am, are you there?
Yes, we are here. Yeah. Dr. Sandeep is
All
also
right.
here. Yes.
All right, ma'am. Your video is turned off. Kindly start the video again. And
Sure.
requesting Small sir to kindly ask your question.
You hear me?
Yes, sir.
Okay, thank you very much. I'm very interested in presentation, and I want to ask you how AI technologies of generative AI can support reduction risk of dementia.
How, according to you, the tech of generative AI can help with
Can help
issues of dementia?
reduction risk of dementia.
Can so can you
How AI can
Rephrase the
help.
question. Sure, sir. So
yeah,
how,
please can you repeat the question?
sure, sir. So how can the tech of generative AI uh, help with solutions for dementia?
So see, AI is a very AI plays a very important role in diagnosis as well as management of dementia. Okay, so we can say AI has two roles: one in diagnosis, one in management. Diagnosis in the sense like it can give us an algorithm by which uh, we can diagnose those cases very early and more important was newer therapies.
So we are losing your audio.
About
Just, just a moment.
okay.
We're losing audio.
I'm audible now. I'm audible
Yes,
now.
you're audible, but the voice is breaking again.
Okay. So, see, AI itself can help in two ways. One is in diagnosing, especially diagnosing those patients who are suitable or eligible for this newer medications like newer anti-amyloid therapy which are available now. They have a very we can say a lot stringent or a strict criteria for including those patients. So AI can help us in identifying those patients who can be eligible for the management for those therapy. Is one aspect. Other aspect is in rehabilitation, like AI can be the bridge between what my brain wants and what I want to do, or like how I can do. It's just like there's something called brain computer interface, which is very common and it's in very nascent stage, where they are trying to uh, use those instruments or those AI external devices to help us to do day-to-day activity. Simple example is uh, a person who wants to go to reach to his house, but he is confused. He cannot go out. Means he's confused and he is lost in his own environment. That there AI can help him by navigating to his house. One more example is simplest one. One of the most simplest is some people want to they some of the patient with dementia they have they they have wandering out. They will go out. They will move around. They will be lost. So if AI just simple GPS, right? Some wearable devices which can help them to map him out, or we can follow them where they are going. The simple wearable Apple devices or any watch or any phone or small GPS devices. This is the simplest which is available now, and definitely AI will have a role in dementias, especially setting up dementia-friendly homes, like Ms. Adia has mentioned before. Dementia-friendly homes where they can use the instruments, where this AI can help them in reminiscence therapy, in reality orientation. Simple one, you can put an alarm clock or Amazon Prime devices which can tell them today is 9th of September, today is or whatever day today is, Monday, today is Saturday. Now is 9 o'clock in the morning, at 12 o'clock in the evening, 9 o'clock in the morning. You have to take this medication which is there in the blue box. This way they can help. Any other?
I've also read about these reports or a study conducted by MIT that AI repeated AI use actually affects the cognitive health of healthy individuals. Like your attention span reduces, your uh, focus or your habit of doing any work or computation work and everything reduces. But directly affects the cognitive health. Isn't it in contradiction to, like, say, trying
Uh,
to improve the health of somebody who's already got it deteriorated?
I will say कि, like, see, it is very different context, but yes, repetitive. If you are engaged in AI, like if you are engaged in your mobile phones or TV, and so you are not going for the social contacts, like you are becoming withdrawn. That itself is a risk factor for dementia, right? So see,
Correct.
everything you have to use in limits.
It
Even
can be
medical
used as a tool, rather.
tools,
It
yes,
can be
yes,
used as a tool, effectively.
yeah. This
I hope,
this should
Shwan sir,
not
your
be
question is answered.
Yes, my question is answered, and I have another short question. I want to ask you what, according to your opinion, need to be a role of governments and authorities in early diagnosis of dementia.
So, to rephrase the question for all the participants, the role, what would be the appropriate role of government authorities to solve problems of people with dementia?
You can,
Yes, I think that would be a very big discussion. But then, yeah, I think nice for a start that we have a dementia policy in place. So, unfortunately, there are not much dementia policies or schemes that support dementia. So, that is something that a lot of people are working on in the Indian context, where we reach out to the government and for a start, like dementia policy. So, a lot of countries have it. Something like UK has Australia. For Australia and Japan, dementia is like priority number one as government policy. So something that we are trying to come, get it in India, that will definitely help. So once the policy is probably in place, with that people will have a lot of help. Maybe caregivers can have help. So however that is defined, that is also a different thing. But yes, when we talk about government of India, I think that is the first thing that came to my mind. But there could be other things like where the hospitals are there. They may be like more aware of dementia. They are able to provide better care for dementia. So a lot of dementia care comes under rehab. So that has to be redefined how it works. So yes, There's so much. Very difficult to answer anything, in this particular time span. Yeah.
Thank you, ma'am.
Thank you.
Thank you, sir. I'm going to unmute. I'm prompting a guest to kindly unmute themselves. Please see the prompt on your screen and unmute yourself.
Thank you.
Thank you, sir.
Dr. Grewal from Delhi. Thank you very much for this effort and on mental health in the elders. We have a hospital in Delhi called the Pacific One Hospital, and I have started an elder care program in that, and that is the first hospital in Delhi to do it. We are planning to have a special package on mental health of the elders. My question to both my experts, first of all, congratulations, beautiful presentations, is we are facing a number of barriers to get the elders to come for a mental health checkup. We all know what to do after we have diagnosed. But I feel that the barrier of getting an elder to get a mental health assessment done is our first challenge. Could you please highlight some ways to overcome this barrier, which is posing a big challenge to us? Thank you for the opportunity.
So, it's very to answer. Right. So, first of all, we should always go to the public. We should also should go to the community. Explain the
So,
need of early diagnosis.
your audio is getting cut quite a bit.
No, the challenge to bring them to the hospital, get them to get an assessment done. I think band is less, so if they close their video and only speak, that may help them. Disconnect.
Right, sir. Let's just reconnect. Just a moment.
Yeah.
Yes. Can you hear us?
Is all.
Yes, we can hear you. Yes. Just
Sorry for this internet issues. Very bad. Okay, so to answer Sir's question, I want to emphasize public education. The only way forward is public education, making the public aware that there is something called cognitive impairment, and there is no stigma associated with it. We should go to the public, go to the community, do uh, patient education programs, all those things. Otherwise, the stigma we cannot cross it. Like we cannot cross that barrier. Uh, like yes, if I said I'm as a clinician, I'm seeing a lot of patients coming here. One patient, I'm just giving, I'm not disclosing those names. People who are highly educated also, they don't come and completely become open regarding the dementia. They don't say like my ward is having memory loss and this thing. They will tell, okay, he has some memory loss. Okay, you just evaluate it and give them medications and let me go. They don't discuss, they don't disclose. Maybe the stigma, or maybe they have some other thing. We don't know that, but we have to go to the community. We have to tell them. See, in my family, few people have some cognitive impairment, which I didn't know. I was not aware of. Now, thinking retrospectively, okay, that could be the cause.
Yes. So I'll just add few things over here, like working with the dementia NGOs, the experiences that I have had, exactly like what Dr. Sandeep has mentioned, that public awareness is definitely the key. First thing, like in the community that you're targeting serves, in Delhi, where you mentioned that you're starting with it. So maybe you can start small and just target the community. And then maybe, that public awareness, screenings. So a cognitive assessment is a very detailed thing that happens in a memory clinic, but there are a lot of tools that are available that can be used as public screening for dementia or cognitive impairment, and that is something a layman can do it. So when you doing such programs like what is dementia, making people understand that it is a disease and not like part of normal aging, the more we emphasize on those things, maybe that stigma and that social pressure will come down. And it has happened over the years. I can say that over the last 10 years, there have been so much change in that approach towards dementia or mental health also. So if you see, there are suddenly so many movies who have come up for dementia, and that will help a lot for the public awareness also. But if you're targeting like a very specific place, then these screenings, as we have done a lot in the peri-urban areas of Hyderabad and a lot of cities, just doing basic screenings for maybe poor people, or sometimes we do it for gated communities, just the basic screening. And in case when we identify that there is a person that can be referred to a doctor, that is done. So that effort has to be there for the public awareness, something very similar to what we are doing right now with help of WishwaTalks, right? That this kind of webinars, or like having the experts talk about the dementia, like what is dementia and what is normal aging. That effort will definitely help to change the way people are perceiving. So there's generally denial also, there's social stigma, there is, and it will take time, but there are so many examples, like there are other associations who are working for dementia. So this will be a best approach, starting with public awareness, screenings, and then that education of dementia coming from the doctors, from the medical team. So that makes a lot of difference.
And to add, I'd like to add something. I think something like this, the awareness of this kind should be also be incorporated with our schooling systems or education systems at a very early age. Like, I think we are barely taught about how to take care of our elderly while we are growing up in schools. We are taught from a very uh, say geographical location aspect, like yeah, culturally you're supposed to respect elders, this that. It can be taught in a more educative, fact-wise manner, and what complications can come in when your folks are getting older, and put them in points, dementia, Alzheimer's, each and everything, and they can they can be given a hint at a very young age, so that while they're growing up, they're more curious about it, and if suppose they come across it anywhere, they'll have the awareness of it, basic awareness, and they'll be able to get in touch with the correct authorities. Um, Requesting another guest to kindly unmute yourself. Kindly check the prompt on your screen and unmute yourself.
Hello, am I audible?
Yes, ma'am.
Okay. Sir, thanks for the session. It was very informative. What I would like to ask you was, my mom is 75 years old. We had doubts whether it is dementia or normal aging. A lot of those myths were actually, cleared because of your presentation. And we had actually taken her to a doctor also. He did some basic tests and he said it is normal aging. What I want to know is that as her age advances, is there any further test that we can do, say something like an MRI or something else, wherein we would be like, very sure that it's not dementia or Alzheimer's? The reason I'm asking this question is because her mother also had Alzheimer's. So if you could give some clarity regarding, like, are there some other kind of tests that we can do just to be sure?
Um, what we can do, ma'am, here is detailed cognitive assessment to see how she is performing on those tests. As I mentioned,
Sir, you are
Sorry,
not
sir, we lost
audible.
your audio. Just a second, sir. You're not audible.
is okay now.
Yeah, better.
Yes,
I'm
sir.
audible. Better, right? Okay.
Yeah.
Yes, sir.
So
You're audible.
see, first of all, if my mother or my father has Alzheimer's, have cognitive impairment, it doesn't mean like I will also have. there is always a risk, but doesn't mean like I always it is always I will end up with dementia. Number two is okay, some forgetfulness. You can go for this detailed cognitive assessment where we can test all the domains and we can say like, oh, there is some impairment here and some impairment there. Then what we can do is an whether there is an impairment or not, like whether she is in a mild stage or in a severe stage. Number two, what we can do is image.
We've lost your audio again, sir. Just a moment. Hello, sir. Your audio is not working at the moment. Just a moment. Okay, I'm prompting you to turn off your video once so that we can check the audio. Hello. Kindly unmute yourself. I've prompted you to unmute, sir. Just a moment, ma'am. We are going to get our guest back onto the network.
Okay, I'm audible now, sir. Hello.
Yes, sir.
I'm audible now. So, see, further tests which are the further tests which are available for diagnosis of dementia are we have CT scans, we have MRI, we have PET scan. But all those things should be done if I have high suspicious of having dementia or high suspicious of having a cognitive impairment. So I will advise you to first to meet a neurologist or a cognitive specialist to do a detailed cognitive assessment. Then we should map out what domains have been affected or what is her score. Then you can go for MRI and PET scan. Now, one more thing I want to add here: if in the MRI brain there is some atrophy, the MRI brain will help in diagnosis, but it never helps to predict the severity of the disease. A patient may have very normal MRI who will be doing performing bad in cognitive assessment, but patient reverse is also true. Patient having very bad MRI showing a lot of atrophy, but clinically he will be in the mild stage or in SCI or MCI stage. So not to worry about now. Ask her keep her active in day-to-day activity, and if you feel there is some worsening, go to a neurologist. You can go for MRI or you can go for PET scan. But better I will suggest you to go to a neurologist or a cognitive specialist who can do a detailed cognitive assessment and can tell you.
Yes, sir. We had taken her to a neurologist, and the cognitive assessment has been done. And
Okay.
he has actually cleared her and told her that it's just a part of memory loss. I mean, slight memory issues as part of normal aging. So I just wanted to be sure that in future, if something happens, so you are saying that the best thing is to just again take her to a neurologist if there is any further deterioration in her condition,
Deterioration.
right?
And also you can go for this MRI imaging.
Okay. Thank you,
So
sir.
in
Thank you.
MRI imaging, it will say if there is an atrophy, then okay, it will say whether the patient may progress to the stage of dementia or not. Okay, but
Okay.
those predictions are also not we cannot they are not clinically so correlate with progression, but we can get we can expect something. Okay, but go for MRI.
Okay. Thank you, doctor. Thank you, sir.
Thank you, Dr. joining us. I prompted another guest to unmute yourself. Kindly unmute yourself. You'll see the prompt on your screen. Okay, I see a guest.
Hello. Hello.
Hello, sir.
Hello.
Yes, sir.
Hello. Can you hear me?
Yes, sir. Can you hear you?
I am Dr. Sundar Rajan, Siddha Doctor. Hello.
Right, sir.
Okay.
Please go ahead.
Even though uh, even though it is a progressive disease, can we prevent the disease in the earliest form? Shall we have any natural remedies to prevent the disease in the earliest form? Natural remedies apart from the modern pharmacological. Can we have any natural remedies and methodologies to prevent the disease at the earliest form, and any other diseases which are associated with the dementia, which fasten the process of dementia? Hello, sir.
Yes, sir. Thank you for the question. We're just waiting for the reply from the speaker. Just a moment.
Okay.
Apologies to all the participants. We've been possibly losing network with the speakers. The speaker is reconnecting at the moment. Kindly be patient.
Sir, as in my slides, so dementia can be prevented. I think dementia, if a person is the disease itself cannot be prevented, but we can scale down the disease progression. We can keep them in a very early stage, uh, or even the pathologies that we may able to keep in that stage. We may not progress to clinical stage by doing normal physical activities, simple things, going for daily physical exercises, learning new languages, music helps, social contact, going out, doing activities. Don't keep yourself idle. And here one more thing is one should always look after their general well-being, like what we say, early to bed, early to raise, keeps women's healthy and wise. So you should keep on time, have a proper sleep, have a proper diet, add lot of fruits and vegetables, don't eat lot of junks, avoid high cholesterol food. All those things helps in preventing dementia. The diseases which are associated with cognitive impairment or
We lost your audio again, sir. Hello, Dr. Sandeep. Your connection is not appropriate at the moment. We can't hear you, sir.
sorry, sorry, my bad. Yeah.
Sir, are you connected onto a mobile hotspot?
Yeah, mobile hotspot.
Yeah.
So you'll have to turn off your notifications and also
Turn off
keep
my.
it on do not disturb. Yes, notifications. And
Yes.
if you're getting a lot of calls, you'll have to. Uh, it's it's because of the
So
calls maybe
coming
why
to
it's getting.
not getting any calls. Now, regarding the diseases which may hamper your, which can hasten cognitive impairment, cardiovascular means coronary artery disease, heart diseases, um, your brain strokes, patients having high cholesterol diet, hypertension, diabetes, all have contributing factor in hastening or in increasing the severity of dementia. We have to control all those things. Mechanism of action is because if you have a heart disorder, there will be as you know, you are having cognitive impairment because of some brain pathology and brain
So
cells
we're
are
losing
getting
audio.
okay.
The audio is getting cut.
Can
It's
I
very
join in
crackle.
Yeah, just can we try to
Yes, sir,
join
please.
from mobile directly?
Is it okay? But that will better,
Yes,
no?
yes, that would be great.
So,
Okay. I'm audible now?
Yes, sir.
Sure.
Yes.
So, now so dementia, sir asked two questions. One is how to prevent the dementia in natural way. Number two is what are the disease associated with dementia which may hasten the disease progressions, right? Preventive strategies, all the things which you are doing now, like having physical activity, be active, go to morning walk, evening walk, socially interact with people, eat healthy diet, add lot of fresh vegetables and fruits in your diet, control your blood pressure, control your sugar, uh, avoid sedentary lifestyle. All this help in reducing in preventing cognitive impairment. Number two is your second, if I'm, and there is no other extra medications or nothing, no natural remedies. You have to be active in your life. Simple thing. Number two is what are the diseases associated with dementias, or which increases the cognitive impairment. One is your heart diseases, ischemic strokes, brain strokes, or other disorders where patient becomes sedentary, doesn't go out. A old person having knee replacement is not going out, not mixing with people, have some underlying cognitive impairment which is undiagnosed. It will increase. Greatest example is your COVID lockdown. A lot of people are coming with memory loss. They have some propensity to develop cognitive impairment, but because they were locked down, they were not able to meet their near and dear, not able to go out, they manifested. Okay. So any disease which makes you bedbound, it keeps you in a room, can hasten your memory loss. Among them, most prominent is your brain stroke and heart strokes. How to prevent? Be active. Try to add be active and lead a healthy lifestyle. I just want to add this two only. I think I hope I cleared his doubt.
yes.
Just asking to. Yes. Sir, I prompted you to unmute yourself. Kindly unmute yourself. Hello. Yes, sir.
One more question.
Yes,
Yes.
sir.
Sir, even though the dementia is associated with elder age groups, most of the children, not most of the children, some of the children are very poor in studies. They have some forgetfulness in their studies. Is it related with any neurological function, or it is an ordinary one?
So can you rephrase the question, sir?
Sir, even though the dementia is associated with elder age groups, some of the younger peoples also are forgetful in nature. How can we differentiate that? Is it dementia, or it's a normal forgetfulness condition?
So, as I mentioned like before in the slide which I kept, which I showed you in my presentation, normal forgetfulness and abnormal forgetfulness. In normal forgetfulness, people we tend to retrace it and we may able to remember it after we think about it. Now you have seen a lot of students coming with, I'm forgetting my studies, I'm not able to remember my topic, but he or she is able to do all his active other things. If you ask him which movie you have seen or who is your favorite actor, when is the next IPL match, they may able to tell. So I won't say like everybody may have that any cognitive impairment. Is more like an attention, is more like an interest. So I am interested in studies. I will read and I will remember. One person is not interested in sports, he will not remember which IPL match happened and who is the winner of IPL 2026 or who is the winner of IPL 2025. So is all more on the area of interest. Now, if if you feel like that memory loss is hampering his day-to-day activity, it is not normal thing. Like after eating food, he will forget whether he has ate food or not. He would be frequently skipping appointments, not on those appointments which he has been forced upon. Then we may feel okay, there may be some cognitive impairment and he should reach to the doctor. And here also, there could be psychiatric or neuropsychiatric symptoms would be also playing a role, like depression. I am depressed. I'm not showing interest to learn things. I may develop forgetfulness. 70 to 60 to 70% young people who are coming to our memory clinic are usually having some personality disorder or some depressive underlying depressive disorders.
Okay, sir.
So
Thank
coming to the general physician is always an important thing, or taking help, medical help is always an important thing.
Okay, sir. Thank you. Thank you.
Thank you, sir. I'd like to ask an additional question regarding to that question itself. So, sir, we have noticed that, I mean, excessive usage of social media, watching reels and everything, but a lot of people have a shorter attention span in today's day due to, say, reel content, 7 to 30 second, 1 minute reel content, and binge scrolling, and then excessive dependency on AI for doing work or for gathering information. So, excessive of doing these things, could they be in the future? Could it be problematic, and could it be leading to Alzheimer's and dementia in some cases?
See, I don't say I will not stamp it like doing these activities or those person who having very decreased attention span because of uh, scrolling reels and all those things will lead to dementia, but it will definitely lead to behavioral issues like depressions, anxiety, socially. They may feel like I'm socially outcast. I have to do a lot more thing. I have to dress in that way. And it's more like a behavioral or your psychiatric symptoms. Uh, Now, these people will develop cognitive impairment in future. Maybe, may not be, or maybe they also play a contributing factor. Okay, so yeah, both can be true. Yes is also true. No is also true. It's a very controversial topic. But okay, but I will advise not to go, not to do those things.
Thank you
It
so
has
much.
become a part
Yeah.
where I think we all are like doom scrolling. But the thing is that that is not the only factor, right, of our cognition. Are we doing other things? Like a lot of us would be like into other skills. So that will help to have a better cognition. So in case like even if we are like doing a doom scrolling, but the rest of the time maybe we are doing some physical exercise or some other activity that will help to improve the cognition. Or some people are into learn different skills, learn different language. So this is like, yes, this is something new that has come, but then there are studies which are saying that it will have some sort of a cognitive impact on. But then if you think of AI, right? So AI, if you even have to ask, you are still using your cognition. Yes, the time span of your answers have become shortened because AI is answering you, but you need to know the right question. So that is the cognition you are still using. So it is a very difficult thing to say, as Dr. Sandeep also said that it's not like a yes or no, but it is overall your cognitive well-being and a lot of other factors. So all the factors like how healthy is your brain with respect to all the other things. How good is your food or nutrition, your sleep, your other lifestyle factors. So it all comes down to like it's a package, not like one thing. I hope that.
Yes, ma'am. Thank you. Ma'am, okay, so the next question is for you. In the slide of normal aging versus abnormal aging, is there a grading or are there levels to it?
No, there is no grading or labels here, sir.
Right.
There's no grading or labels, but you have to be see that is
Okay, sir, you're on mute. Your mute button has got pressed.
so it's just
Thank you.
like the slide is a lot of people are coming and telling I have forgetfulness, I'm not able to remember name, I'm not able to follow the instruction. It's for that thing. Okay, there is no
Right, sir.
staging, no grading. So staging and grading are those person who have cognitive impairment.
Right. So, out of all of the kinds of dementia-related uh, diseases that you mentioned, which one is the commonest?
Alzheimer's is commonest. Okay, but in the Indian context, I will say the mixed dementia is much common, Alzheimer's plus vascular. But worldwide, Alzheimer's is always common. Alzheimer's is like
I'm
most
sorry,
people who come with
your audio is lost when you mentioned the last thing.
Okay. So in worldwide context, Alzheimer's is the most common cause of dementia. Indian context, I feel mixed dementia is very much common. Mixed means Alzheimer's with some component of vascular dementia, like both the pathologies are there. And Alzheimer's, they usually present with memory loss, like forgetting things, forgetting appointments. They don't have so much of behavioral issues. Okay, and Alzheimer's is the most misdiagnosed. A lot of dementia patients are diagnosed with Alzheimer's. They may be having some other cause of dementias, and patients with Alzheimer's are also least to come to the doctor.
Yes.
Because they don't they have only memory loss and people feel like okay I have some he is forgetting because he's old age and they won't be showing any behavioral issues which cause any issue behavioral symptoms which are distress to the caregiver, so they don't reach to the doctor. So if you ask for the hospital data, FTD is more common. In general, Alzheimer's is common.
Thank you so much, sir. So there's a question from Mr. Sarah. Are there any devices available for assessment of cognitive functions?
Not devices as such. We have questionnaires where we do the assessment and we ask some questions which are particular to each domain, and we get a score, and it tells us like in which stage the patient is.
The next question is from ma'am. Does RTMS therapy is RTMS therapy a good option for dementia care? I mean, not really. You're on mute again. Just a moment.
Yeah. Okay.
Yes.
So, does it mean the reminiscence therapy?
I think so. It's mentioned in abbreviation RTMS therapy.
So RTMS is transmagnetic stimulation therapy.
Okay.
So I will answer it. So transmagnetic stimulation therapy doesn't have proven efficacy. There are not much papers, but some few case report. They say it works. They say it not work. But it is not a established or approved therapy for cognitive impairment.
Right. Thank you. So, sir and ma'am, could you all guide on how to set up a memory clinic?
Okay. Yeah, sure.
Trivial.
So, yes. Yeah. So what can be done is, say, memory clinic needs a couple of things which are like the crucial points of it. Like there has to be a medical doctor. So it can be like a neurologist or a psychiatrist. generally a neurologist works best, but then it can be a combination of these two. There has to be maybe a psychologist, someone who can do like assessments, counselings. So memory clinic is basically like, a combination of people. Then we have like speech therapists, we have occupational therapists. So this is like, that is the, but for a start, you can just have like, the medical doctor and maybe a psychologist or a counselor who can do the assessment. So here, memory clinic establishment is more like what is the role that you're looking for rather than what people you're looking for. So it's like you can have assessment, screening, assessment, diagnosis. So some memory clinics will not necessarily they will have a doctor, which means that they're not doing a diagnosis. So you have to be defined on, what exactly you want to do. But the ideal thing is like there is a screening, there is a diagnosis. So for the sake of diagnosis, you need a doctor there. And then there are like, post the diagnosis, there is counseling and the other interventions that all happens in the memory clinic. So I think it is more to get the idea of like, how you would like to have the setup. So basic needs, I think I have mentioned it.
Thank you, ma'am. And the next question is from Sakshi. Sakshi is a counseling psychologist, neurodivergent population. I am practicing for 3 years now. During my PG program, I did my internship in geriatric department. Time and again, I get back to problems related to um, old age population.
Related to?
Still don't feel confident is related to old age population. Still don't feel confident enough with practicing. So keep on referring clients to others. If you can guide me with any problem or books to refer to, I will be very grateful if you can.
Well, I can look
It's,
up to something and get back on this, but
sure, you can send it to
some,
my team and we can send it to them via
yeah.
email.
When we are talking about more of a geriatric counseling, it is more of a different population that you are seeking for. So, it is the geriatric population, right? So, I can't name a book right now, but maybe I can look up to something. And yes, it is more to do with the experience also. Yeah. So, let's see if I can help you with that. Yep.
So thank you. You can send the links to us anytime and we'll share it with the person who's asked the question. Okay. As of now, how many patients are at what stage of dementia, Alzheimer's? How much percentage in stage one or stage two or so? Okay.
Yeah.
That would have to be a very comprehensive study, whereas I don't think such a study would have been made appropriately in the country.
Then the maximum number of patients are still in stage one and stage two. But if you look at the hospital data, it will be more. They will be on stage two or stage three. Because people they don't come till the patient is behaving very abnormally or her activities are or impairment is hampering their day-to-day activities. Small things they don't come. It is true for all diseases. It's true for dementia. Okay. See, you won't be reaching out to a cardiologist till you have a massive heart attack, right? Some chest burn, you may feel like a small thing. I don't want to go out, right? Similarly, it is holds more true to the people with dementia. Like, okay, he is having some memory loss, and because of the stigma and because of those lack of awareness, most people they don't turn out to the doctors. Hospital data, you will find maximum number of people are in stage two, stage three. Community data, 90, 70 to 80% are still in stage one, stage two. Stage zero, I will say stage 0.5 in stage one.
But I'll just add it like see the number that we quote, say there are more than 9 million people living with dementia. So it is not like they are per stage. Anyone who develops dementia will start like, early stage and go to moderate and severe stage. Yeah, we may not have that kind of studies to say what particular, but anyone who is diagnosed with dementia will eventually from an early stage to moderate stage and then, severe stages. So, yeah,
And that too,
that's
with the number of people who have been undiagnosed, also very unclear. I mean,
yes, yes, true.
because of the social stigma and everything, so many people wouldn't be going for the tests itself. So, long way to go there. Uh, Sakshi ma'am has asked for your contact details. We'll send in the
It's on the last
corresponding email.
slide.
Yes, yes, we'll share the last slide. We'll also share the contact details with ma'am after the session. Okay, your screen is stuck. Anyways,
Yeah.
I think we've covered all of the questions in the chat box and also the ones that were raised personally by people. With that, I'd like to now conclude this session. Thank you so much, Sir Sandeep sir, for joining us. It is a pleasure
Thank
having
you.
you with us. And like always, ma'am, it's always a pleasure to have you with us. Thank you for joining us again for your time and
Thank you.
patience.
Thanks. Yes.
Uh,
It's a pleasure.
so you, thank you, ma'am. You will shortly see a link of the breakout room link on your screen, sir. Kindly join into it, and I'll be with you shortly. Uh, Meanwhile, for anybody who's missed any part of the session or would like to go through the previous sessions, kindly join, visit our YouTube channel. I'm sharing the link of that again in the chat box.
Sorry.
So
Okay. Requesting all of you to share the link. You can also just visit WishwaTalks YouTube channel, WishwaTalks. If you just type this on YouTube, you go to the page, the last talk that will be mentioned will be today's session. You can also check out all the previous sessions. And we will send in the PPT of this particular session along with the recording to your respective registered email IDs. Thank you for joining us. Hope to see you next week again. Thank you.